Welcome to ATCM, the emergency medicine channel. Shall we start,
Okay.
sir? A 78-year-old female presented to ER with complaints of excessive fatigue and daytime sleeping into 5 days. Also, cough with expectoration and breathing difficulty since last 3 days. On initial 10-second assessment, airway, patient is coming to initial 10-second assessment. Patient is drowsy but arousable, oriented to time, place, and person. Airway, patent, no pooling of secretions, no stridor or no hoarseness of voice. Coming to breathing, patient has slow, shallow
What is the
breathing.
basic difference between stridor and wheeze?
Stridor is audible. It's
Wheeze
usually
also-
inspiratory.
Okay. Wheeze is
Expi-
inspiratory or
or
expiratory?
expiratory.
Okay. Stridor will not change with the
Position.
or cough, pause cough. It will be fixed. Okay. Fixed obstructions produces stridor, whereas movable obstruction produces wheeze.
Wheeze. Breathing, sir. Patient had a slow, shallow breathing. Respiratory rate was around 10 breaths per minute.
Okay. What are
SPO
the conditions you get bradypnea like this?
in neuromuscular weakness like myasthenia gravis, sir,
Myasthenia gravis.
or GBS can also have
Okay.
patient. Or patient with altered mental status,
Middle,
and brainstem lesions or brainstem bleed and all of that.
Then
Then in myxedema,
myxedema,
hypothyroidism,
hypothermia,
myxedema,
raised ICP. So many conditions can produce bradypnea.
bradypnea.
It is not a safe condition. It's a dangerous situation.
Coming to SpO2, it was 84% on room air, and on auscultation, patient had bilateral creps, right more than left, with occasional wheeze. So we initiated on 5 liter O2 via mask and bronchodilators. Coming to circulation,
What is the need of bronchodilator in this patient?
patient had wheeze, sir.
Wheeze.
So some mucus plug obstructing
Okay.
some. Coming to circulation, patient heart rate was 52 beats per minute. BP was 100 by 60 mmHg. Capillary refill time was more than 2 seconds with cold. Patient had cold cami extremities. Coming to disabilities, GCS was E3, V4, E3, V5, M6. Exposure, patient was febrile. But usually, coming to adjuvants to primary survey,
Exposure, what all things you check in a ER patient?
temperature and GRBS has to be checked. Here,
What action you take immediately after exposure? Here the temperature
this
is
is
low. What is the immediate step?
rewarming has to be done.
So you have to immediately rewarm the patient, or try to rewarm the patient. Give cover to the patient. Have you done that?
Sir, here the temperature was normal actually.
The hypothermia was there, no?
No, sir, no hypothermia.
Okay.
Sometimes in if it is hypothyroidism, if patient is having underlying infection, temperature can be normal.
Okay.
Coming to adjuvants to primary survey, we took an arterial blood gas. So pH was 7.38, but PCO2 was 71.8 and bicarb of 32. So patient had a chronic respiratory acidosis with compensatory metabolic alkalosis.
Central hypoventilation syndromes. What are central hypoventilation syndromes?
It can be central sleep apnea
Sleep apnea syndrome.
then brainstem bleed and stem bleed lesions.
Okay. Not only bleed,
Lesions.
chronic lesions. Okay. Then this case, hypothyroidism is one of the
common cause of central hypoventilation.
Both hypothyroidism and hypothyroid coma. Hypothyroidism itself will produce slow breathing. Okay.
Coming to CBC CRP, total count was 15.5, HP was 12.8, platelet was 380,000, CRP was 55.8. So coming to ECG, patient had sinus bradycardia. Coming to sample history, a 78-year-old female.
What are the changes produced by hypothyroidism in ECG?
Patient can have sinus bradycardia. Patient can have blocks also, complete heart blocks. Sometimes bundle branch blocks also can be seen.
Other than that,
Swanberg's hypothermia test. Then electrolytic imbalances can also.
ECG. ECG.
Low voltage.
Voltage. So low voltage complex with bradycardia is the most common finding you get in ECG. Then, like you told, Osborne waves. Osborne, no? Osborne or Osborne?
Osborne
wave. What is Osborne wave?
seen in hypothermia.
What is that?
J point
elevation. Okay. So that is a sign of hypothermia, not the hypothyroidism. Hypothyroidism classical finding is bradycardia with low voltage complex. Why low voltage complex?
Sometimes patient can have pericardial effusion.
Okay, myxomatous
pericardial
fluid will be around the heart. So that produces bradycardia. Normally, pericarditis will produce tachycardia. Hypothyroidism is one condition where you get bradycardia with low voltage complex. Once you see bradycardia with low voltage complex, you have to always think hypothyroidism. Tachycardia with low voltage complex, so many conditions you get. Okay.
So we'll come to sample history. A 78-year-old female patient is a known case of systemic hypertension and recently diagnosed multinodular goiter with retroclavicular extension. Status post, patient underwent thyroidectomy 15 days back from outside hospital, and there was no records of her being restarted on any replacement thyroxine post surgery. So patient
for the past problems during surgery this patient can have if you are working in a hospital where thyroid surgery is very common. Okay.
One post thing surgery is hematoma causing obstruction can happen immediately after surgery, and after some time recurrent laryngeal nerve injury, vocal cord palsy, hoarseness of voice.
During the surgery or immediately after the surgery?
Hematoma causing obstruction is...
That is okay, surgical complication. That is also possible. Hyperthyroid storm. During surgery, if not controlled well before surgery. That is a very common thing, but nowadays we are not seeing because it is well controlled nowadays.
Yes.
Okay, but like you told, hematoma and surgical complications are more nowadays. So, and like you told, hypocalcemia is one of the most dangerous problems, which will be unnoticed. Nobody will start the calcium, and many patients will come back with hypothyroidism. Okay.
So for the past 10 days post-surgery, she has been experiencing increased fatigue, lethargy. Family also reports that she has been sleeping most of the day. Also complains of constipation since last day. From past 3 days, patient developed, initially patient had nasal congestion and sore throat, later cough with expectoration and progressed to breathing difficulty. No history of fever, chest pain.
Partial thyroidectomy or complete thyroidectomy?
Complete thyroidectomy. No history of fever, chest pain, palpitation, syncope, vomiting or any recent trauma or fall. So we came to a provisional diagnosis that post-thyroidectomy, hypothyroidism, myxedema, which was caused by LRTI, precipitated by LRTI.
What investigation you will send from ER? You have started oxygen that is covering the initial ABC. There is no hypotension, there is no severe bradycardia, only desaturation was there. We started oxygen, that patient improved. What other investigation you do meanwhile?
Myxedema is mainly clinical diagnosis, but before starting the treatment, we are supposed to send TSH, thyroid profile, cortisol, and precipitating factors, whatever we are suspecting. So CBC, CRP, ECG.
Basic investigation, one is TSH is a must. Then
cortisol, T3, sometimes underlying adrenal insufficiency also we have. Infection panel.
ECG.
Then RFT, LFT has to be sent.
You can send. I am asking X-ray. Specific questions. Specific investigation which will be done only in this case. What else? They are told something. I have to calcium. So this much investigation is a must. Other things, if you want, you can send. Okay, what happened to all these investigations? What is TSH value?
30.8.
30.
Okay. T3, T4 was reduced. T3 was 0.58. T4 was 0.25.
TSH is very high. Yes. She is in hypothyroidism. Okay. Then
T3 was 0.58, very low.
Hypothyroidism. Calcium?
Calcium was normal.
Okay.
9.4. Bradycardia.
Then one more counts.
Counts was elevated. Total counts was 15.8. CRP of 55.5. And X-ray showed right lower zone consolidation also.
Right lower zone consolidation. What will you suspect? Right lower zone consolidation in a patient who underwent surgery in recent past, 1 week back, was tubed. What will you suspect?
Atelectasis. Post.
tube was placed last week. She was extubated and discharged. Came back with consolidation. What will you suspect? Even if the patient is not on ventilator, there is a chance of you have breached the protective barrier. So there is a high chance of hospital-acquired infection in this patient. Okay, maybe community-acquired, but we have to think like that. Otherwise, we will miss that. Okay.
So initial supportive
management. What is the procalcitonin level?
Is 0.1.
0.1. Okay.
So initially we started on supportive measures. Patient, since there was respiratory acidosis, we initiated on NIV. So we started on then continuous cardiac monitoring and BP monitoring was
done. You
done.
told atelectasis. Is it possible in this case?
Yes, post intubation.
Hyperventilation is possible because procalcitonin is very normal. So there is a possibility of pneumonia, but as per your this one, procalcitonin is very low. Then post extubation, atelectasis in upper lobes are common, especially after thyroid surgery.
Okay. So we initiated on thyroid replacement therapy after sending TSH levels.
How do you start thyroid replacement therapy?
First, we have to give 4 loading doses, T4. Either we can supplement with T4 or T3. Okay. Especially in elderly and cardiac patients, we prefer T4 compared to T3.
But here what we have?
T4 only. Levothyroxine tablets we
don't have any other option. You have only one option. So how do you give that? How much tablet you give?
4 mcg per kg has to be given. Here, after calculating, she was around 55 kgs. So 75 mcg, 3 tablets was given initially.
So normally, most of these patients may require at least 3 tablets of 100 microgram. Most of the patients. Depends on the weight, it may slightly vary. If you don't know to calculate, just give 3 tablets immediately. Okay. What will you monitor when you are giving high dose thyroid to a patient? You know here it is thyroidism, but when you suspect itself, you have to give thyroid tablets. You may get the result afterwards. So after starting 3 tablets, how will you see the response?
Patient's bradycardia will start improving.
It will go to tachycardia. It is the best improvement sign you are going to see.
Yes.
Now what happened after that? What all other things you had given?
Then steroid, hydrocortisone 200 mg
can be given, especially when there is hypertension. So here there is no hypertension, but this patient may go to hypertension after some time. Okay,
then continuous 1 hour. After that, we have to give 100 mcg after 20 minutes, then 50 mcg. Then we should start on replacement therapy according to the weight of the patient. Then after 2 hours, we took an ABG. And
what is the replacement dose normally? How much it will come?
70.
1.2 microgram per kg. Approximately. So if it is 70 kg, mostly she may require around 100 microgram per day. Okay.
So after repeating ABG after 2 hours, the patient has doses had come down and brady also improved. Patient had a heart rate of around 78 to 80 later on. And initially when she came, she was drowsy, but later on she was responding and she was becoming better and she was admitted under endocrine for observation. Coming to myxedema crisis, it is a metabolic and multi-organ decompensation characterized by uncorrected hypothyroidism with altered mental state changes or coma or hypothermia, temperature less than 35.5 degrees Celsius.
Temperature was normal.
Yes, sir. So maybe an underlying infection would have caused.
So what antibiotic you preferred here? They gave for this patient?
So injection ceftriaxone was given one. Clinical features include patient can have, because of slowing of metabolism and accumulation of mucopolysaccharides, can cause non-pitting edema, especially in the face.
What other condition you get non-pitting edema?
Filarious lymphedema.
Lymphatic edema.
Then patient can have bradycardia with hypotension because T3, T4 is important for enhancing beta-adrenergic receptors, and then patient can have hypothermia due to reduced thermogenesis.
The patient admitted in ICU is having TSH 15. Okay, heart rate is only 50. How will you start a thyroid tablet? This is Myxedema Coma. Specific guidelines are there, nothing to worry. In that type of patient, an elderly individual is admitted to your ICU, whose the TSH is 30 like this, but fully conscious oriented, heart rate is only 50. How will you start thyroid tablet? Will you start?
Elderly patients 12.5 to 25.
So there you start very low dose, 25 microgram every day, and slowly build up the dose. Otherwise, what will happen?
Patient can have cardiac arrhythmias.
Cardiac arrhythmia. So tachycardia happens. Most of these patients will have ischemic heart disease. So never start high dose in elderly individual. Young patient, you can directly start 100 microgram.
Okay. Then other clinical features include hypoventilation, especially due to decreased respiratory center stimulation and respiratory muscle weakness. Then altered mental status due to cerebral hypoperfusion, carbon dioxide narcosis, or hypoglycemia. Then precipitating factors include infection, cold exposure, trauma.
This patient sugars were
normal. It was 100 mg. MI, stroke, congestive cardiac failure, or GI hemorrhage, or some drugs, burns also can precipitate this. Laboratory investigations, like we discussed before, we have to send all the T3, T4, CBC, CRP, RFT, LFT, and calcium levels also. Then initially we'll give support.
What happened to sodium?
Due to excessive accumulation of fluid, or due to excess release of vasopressins, hyponatremia can be seen. So water retention has to be done.
Most of these patients will have hyponatremia. Should be treated?
No, water retention is.
Just leave it like that.
Then, like we told, thyroxine replacement has been done. Either we can give T4 or T3. Here, T4 tablets is only available, so we initiate with levothyroxine.
Okay.
And then steroids also we can give.
Iodine? Iodine therapy is required or not?
Iodine therapy.
Books might have given, but we don't give.
Give.
Okay. What happened to the patient afterwards?
Patient became symptomatically better, and he was at X-ray. So right lowers on.
That's all.
Yes, day before yesterday, sir.
Okay.
We'll have to repeat.
Anything else you want to add? Nothing more than this. Everything is covered in detail. Okay. Any doubts? If you have doubts, you can ask. Okay. Thank you.